I think that the world of commissioning is going to change with these proposed moves that are set out in the Integrated Care Next Steps document, which was published sort of the end of November by NHS EI. And where that's headed is obviously that the integrated care systems are going to take a clearer role, and we're going to have a single clinical commissioning group at that level. And there's going to be a more prominent role for provider collaboratives. So actually, the ICSs as commissioner will be more strategic, and some of the tactical decision making around the investments will be made by providers and groups of providers probably. And where the discussion lies at the moment is, what does that actually look like?
Yeah. So
we have some experience in mental health services, and we're about to go live on the 1st of April with a provider collaborative with our colleagues Cumbria, Northumberland and Tyne and Wear around some of the specialised commissioning services. So they're the regional level services around adult secure services, CAMS, and adult eating disorders. So we're going to have the thick end of £100 million turned over to us and be given responsibility to invest it for outcomes. And I think that's the direction. So we're going to see a lot more of that. And the conversations that they're having is, well, what makes sense at a regional level? What needs to happen across groups of similar sorts of providers? What really needs to happen in terms of place-based discussions? So in our York discussions, we're having conversations around, well, there is the potential for the acute trust and the mental health trust, primary care, the VCS and social care to do something jointly on that basis. Very much focused on the needs of York. Whereas, as I say, with some of the specialist services, it would be, what can we do across the footprint of the North East and North Cumbria? So it's going to be horses for courses, and I see it being, no less complex than we are at the moment with some of our arrangements, but actually we're going to need to think about some of our capabilities and capacity to facilitate some of that decision making, to account for some of those decisions, and to manage some of the subcontracts and all those sorts of things that come through, and just generally taking on that broader role as commissioning leaders.
Do you see that, say that you get that £100 million handed over, do you see that as an opportunity to really do things differently, or is it really a case of more of the same, but you're just signing the check at the end of the day?
Well, it'd be a waste of time if it was just more of the same and it's just a different signature on the check. So, one of the opportunities around this agenda, particularly take the children and young people's aspect, is that one of the wrongs that I've already mentioned this, I haven't got a big hangover about it, but the Lansley reforms was that it fragmented specialist commissioning from local commissioning. So we were having regional decisions taken about things like CAMS inpatient services, and then local decisions being taken around the community part of that. So by putting that back with providers, it allows people that have got oversight of that whole pathway the possibility of actually making some sensible decisions that might mean that we can perhaps manage demand or create different sorts of pathways, create better transitions, whatever it is. We've got the kind of insight and the ability to actually influence things on that basis. I think that it'll move to more of a kind of planning type model rather than a straightforward commissioning. There'll be clearly aspects of the commissioning process. But it needs to be a bit more considered, I think, than some of the way that commissioning's worked in the past. So I think that's the potential, is that we can make considered steps that make sense, that help us with the interface between different parts of pathways, and allow us to do that.